Great. Thank you so much, Brooke, and thank you everyone for joining. Next slide. So this is how we're planning to structure our hour together today. I will begin by covering the care management landscape, so some trends that we've seen in late 2019 and in 2020. And then we'll turn it over to Darian, who will provide an overview of our new care management suite and how our new tools can meet the needs of each of the trends that I'm going to cover. Darian will then demonstrate our new products. And finally, at the end of the hour, we will open it up for questions and we'll do our best to answer any questions that you have. Next slide. One more. Perfect. So as I mentioned, I'm going to cover a number of trends and updates that we've seen in the care management landscape. And the first trend that I'm going to be talking about today is around Medicaid populations and the successes that we've seen this past year in Medicaid-focused care management models that really have yielded a lot of success and improvements, both in terms of clinical outcomes and spend. I'm going to double click on one model in particular, and that is the model of CareMore. I'm going to show a trial done by some of my colleagues at CareMore Health in their Memphis location. This work was published this past year in the American Journal of Managed Care. And what the folks at CareMore did is they randomized around 250 Medicaid patients who were super complex, and actually the patients were a bit younger, they were in their 40s, and they randomized them to either routine care or a complex care management program that they developed, led by community health workers and social workers and primary care docs. And what they found in this randomized study was that the program had really impressive and impactful results, as you can see here. There was a statistically significant reduction in total medical expenditure of about $7,700 per member per year. There was a reduction in inpatient bed days, a reduction in admissions, and a reduction in specialist visits. So pretty good results across the board. And so I've chosen to highlight this study for two main reasons. The first is just that I think it's really notable that it showed such significant reduction in spend and utilization for Medicaid populations. And we've actually seen this replicated in a number of other studies and models in the past years. And what it suggests to me is that I think Medicaid patients who have traditionally been thought of as harder to care manage due to some of their complexities, psychosocial complexities, social determinant of health needs. Well, these patients are in fact great candidates for complex care management programs, and in terms of outcomes are as good or potentially even more impactable than Medicare patients. So that's very interesting. I think as Medicaid ACOs have proliferated in recent years, we're going to continue to see more Medicaid-focused care management models with similarly strong outcomes. The second reason that I chose to highlight this paper was that I think they had a notable use of data, and I really wanted to focus on that with our time today. And that points to a trend we're seeing across the board, which is a desire to integrate as many disparate data sources as possible to identify the right patients for an intervention so that you can have results that are as impactful as the folks at CareMore did. I'm going to quote a couple sentences from the discussion section of this paper where they say, and I quote, "Patterns of utilization in the two study groups underscore the importance of precise patient targeting. To be most effective, complex care management programs should target patients at risk of persistently high spending and those whose spending and health outcomes are amenable to complex care planning and engagement." And then the article goes on to say that many care management programs just use claims data to identify patients, but that at CareMore, their approach was what they described as a hybrid strategy, and they integrated historical claims data, predictive models, and also clinician judgment. And so I wanted to point this out because I thought it was really powerful and is a trend that as a company, we're seeing across the board, which is the need and the desire to leverage as many data sources as possible to identify patients who are most impactable for an intervention, with the goal of identifying patients who are both high utilizers, yes, but also those who have utilization that's potentially modifiable by a care management intervention. And I think leveraging broad data sources really makes that possible. Next slide. So still on the topic of data, algorithms, and prediction, I wanted to touch on a second trend, which is from earlier this year, but actually is very timely in this exact moment in history, which is a shift away from closed, opaque, non-transparent risk algorithms. And what prompted this trend was a paper published in Science this past October, written by some colleagues of mine. And what the paper showed was that amongst one specific commercial risk prediction algorithm, though we've seen this replicated in other algorithms, but in this one specific commercial algorithm that was aimed at identifying high-cost, high-need patients for care management, it was shown that the algorithm was systematically biased against specific racial populations. And in this specific study, what they found was that at a given predicted risk score, Black patients were considerably sicker than white patients. And when they remedied this disparity, when they adjusted for it, it increased the percentage of Black patients that were identified as high risk and thus would have received additional help from 17.7% up to 46.5%, meaning that this algorithm that the paper studied was really systematically under-identifying specific racial groups for care management programs. So then the authors asked, why was this happening, and actually published a really interesting follow-up discussion paper in Health Affairs. And where they landed was that in this paper and with this algorithm, the bias was thought to arise because the algorithm was relying on healthcare costs rather than illness as an input to the algorithm. Or put another way, the algorithm was predicting future healthcare costs rather than an individual's actual severity of illness. And so because of this, unequal access to care was a really big factor and meant that we know we're spending less money caring for certain vulnerable populations. And thus, because of that, there was an appearance of lower healthcare costs, which predicted, in theory, future health, as opposed to using actual severity of illness as a proxy for health. And so from this, large racial biases arise. And I think that this has opened up a really interesting conversation. In the care management landscape, what I'm seeing is that this has prompted many healthcare systems and many care management programs to look more deeply at how they are predicting risk and what inputs they're using, and to move away from closed, non-transparent algorithms to make sure that they're really able to look under the hood of what they're using to predict risk. And so in addition to using as many data sources as possible, there's also a strong desire to use a transparent and configurable algorithm as a foundation to ensure equitable patient identification and to really work on eliminating bias. And I think that's something that we're seeing a real commitment for right now, something that health systems are demanding. So that's a second trend that I wanted to touch upon. Next slide. The third big piece of care management news this past year, and I'm sure you all saw this and read this, highlighted the importance of evaluation. And this is the story of the Camden Coalition's care management model. And I think really told a strong message about the importance of evaluating impact. And so this paper was published in the New England Journal of Medicine this past January, and it reported on a randomized controlled trial evaluation of the nationally acclaimed and replicated Camden Coalition model. As I think many know, this is a very hands-on, high-touch model. It's transitional care management or post-discharge care management, and it's focused on vulnerable complex patients, both Medicare and Medicaid, but a very vulnerable superutilizer group. And what this paper showed, unfortunately, is that this intervention had no statistically significant impact on the primary outcome of the study, which was 180-day readmission rate. And this was a very disappointing result because prior studies of this work, which were done in pre-post analysis, actually showed a reduction of admissions by 38%. So randomizing and doing this rigorous evaluation and showing no impact was both surprising and disappointing. But at a higher level, I think what this points to is a known challenge in evaluating care management programs, which is this concept of regression to the mean, where we know that sick patients identified for care management are likely on their own to, in time, get better and have lower future hospitalizations, lower TME, just with the tincture of time. That'll happen to patients that get care managed, and it'll also happen to patients in a control group. And I think that's what led to the difference in results that were yielded from this more recent trial. And so I think from this, we see a real emphasis in the discourse and in conversations I'm having on the need for rigorous evaluation. I'll say, of course, there's a balance needed. We need, it's normal to need short-term evaluation and short-term results to make decisions. You can't always wait for a multi-year randomized controlled trial, but I think that this also emphasized the importance of longer-term rigorous evaluations to make sure that a program really is impacting care and having an ROI. Next slide. So this is the last trend that I'm going to be covering today before we turn it over to Darian to introduce our new care management suite. And this is sort of the elephant in the room, which is obviously COVID-19 and the way that this pandemic has shifted so many elements of our society. And as part of that has had a very significant impact on care management. Firstly, I'm going to touch upon the fact that COVID-19 has transitioned most of care management to being virtual or remote. And this presents a challenge. I think it also presents an opportunity, but it is a difference in the way we do business. Based on evaluation, most remote care management programs historically have not been effective. We know that care management models that have a larger in-person component tend to be those that are more successful, whether that's the CHW impact model at UPenn or one of the programs that I'm affiliated with, the ICMP program at Partners. These models have large face-to-face elements, and it's often thought that that's part of the secret sauce of what yields such a strong clinical and financial impact. And so shifting much of care management to a remote setting has really changed workflows and the care management experience for both staff and patients. I think it presents an opportunity. It's a new way of doing business, but it's a very big change to the way that we do care management. Next slide. And in addition to changing workflows for care management, a second element to consider in the care management space as it relates to COVID-19 are the new populations of patients that are now in need of care management. And so one that I want to touch upon are patients that are at high risk of poor outcomes from COVID-19, meaning patients that need care management to avoid getting the virus. And I think in conversations with colleagues and in looking at what we've done at Partners, different systems are approaching this in different ways. I don't think there's yet a studied or proven model. I've certainly seen systems where patients that are at highest risk are really being kept out of the healthcare setting, receiving mostly virtual care, home services, home labs, paramedicine. I've seen other models where clinic operations are being altered with specific hours for high-risk patients, lower density times in the clinic, separation of respiratory versus non-respiratory clinics. So various different approaches, no proven model yet, but multiple types of innovation to keep patients that are at higher risk of poor outcomes safe. But that begs the question, how do you identify these patients when this pandemic and this virus is so new? I'm highlighting here an article that was published in BMJ just last month. And this article looked at 5,279 patients that were admitted with COVID-19 to the NYU network, both in New York City and Long Island. And this article looked at patients that had what it defined as poor outcomes. And it defined poor outcomes as patients being admitted to the hospital, as opposed to those who could be treated in the outpatient setting. Those that had critical illness, it defines that as needing an ICU stay or a ventilator, and those that were discharged to hospice or those that passed away. And then using regression modeling, it analyzed which patient characteristics were predictive of these poor outcomes. And what they found was that the strongest risk for hospital admission was associated with age, with an elevated odds ratio for age groups over 44, most significant for age greater than 75. And other risks that were statistically significant were heart failure, male sex, chronic kidney disease, any increase in body mass index, BMI. And the strongest risks for critical illness, as opposed to any poor outcomes, were age, as well as heart failure, BMI, and male sex. And so I thought this was really interesting because this suggests to me that there's a new cohort of patients who are at higher risk of poor outcomes from COVID-19 and may need specific care management and are going to need to be identified for these interventions. And what I think is so interesting and a little tricky is that phenotypically, these are similar patients to who we already care manage, right? Those that are listening on this webinar that are in the care management field know that a patient over 75 with CKD and heart failure sounds like a patient that is already in care management. But what's a little different is that these patients may not previously be high utilizers, meaning these patients may be vulnerable, but may not historically be identified for care management based on their utilization. And so this likely creates a need for new algorithms and new ways to identify these patients based on their clinical conditions, and also will likely create a new crop of care management programs and new ways to keep these patients safe and out of the hospital. Next slide. So the last point I'll make about COVID-19 and the way that it's changing care management, in addition to changing workflows and creating a new algorithm of patients for prevention, is that we also are seeing a new need that COVID-19 is presenting, and that is the need for care management for survivors. I think many in the field suspect that survivors of COVID-19 are going to have unique long-term sequelae, respiratory complications, patients discharged with long-term mechanical ventilation needs, on dialysis, with PTSD. I think the list goes on, but the disease is new, and so we haven't had the opportunity yet to study what the long-term effects are going to be and to really think about how to manage them. So we have to use proxies, which are former diseases like SARS or Middle East Respiratory Syndrome, just to predict as best we can what some of the long-term impacts may be, though they're far from perfect and are different diseases pathophysiologically. But using SARS as an example, I included this paper on the slide, which is from Thorax, and looked at long-term effects. And we see that at 6 months, about a third of patients had ongoing radiographic abnormalities, about an eighth had impaired pulmonary function, and there was also reported ongoing functional disability, with some impairments seen actually at 15 years post follow-up. And so I think it would be reasonable to anticipate that there will also be long-term impacts of COVID-19, though we don't yet know what those are. But based on this, I think we're seeing another need and another use case for care management, which is going to be taking care of and coordinating the care of patients who have survived COVID-19 and are now medically complex. So I'm going to pause at this point, turn it back over to Brooke. We've covered a couple trends today related to care management, related to the need for disparate data sources, successes in the Medicaid population, a desire for transparent algorithms to avoid bias, the need for rigorous evaluation, and then some of the new challenges that COVID-19 is posing. I'm going to turn it over to Brooke for this poll question, and then Darian's going to address each of those trends and how our new suite of care management technology can support them.
Great, thanks, Amy. I'm going to go ahead and launch this poll question for us. So we'd like to know, to what extent has COVID-19 affected your system's approach to care management? Your options are that you've doubled down on care management, no change, you're continuing with the status quo, or you're continuing prior programs but working in new ways, such as virtually or with telemedicine, or you can select that you've scaled back and halted care management. I'll give you a couple seconds to get your answers in. We appreciate you voting. Looks like we've got some more votes coming in, and we will go ahead and close the poll and share the results. So 9% said they're doubling down on care management, 16% said no change, continuing with the status quo, 68% said continuing prior programs but working in new ways, and 7% are scaling back or halting care management. So thanks for sharing that with us. It's interesting to see how everyone's reacting to COVID-19 with their care management program. So thanks for sharing that. I'll go ahead and hide the results and pass it back to you, Darian.
Thank you, Brooke, and thank you, Amy. I'm excited today to introduce to you the new care management suite. I want to discuss how the new suite uniquely adapts and meets the needs of the recent trends and the updates that Amy just went over. So to start, I want to introduce our care management framework. It all starts with our approach. Health Catalyst took a data and analytics-driven end-to-end approach with transparent and flexible algorithm logic and patient-centric views optimized for care management workflows. So with that in mind, I'd like to introduce the products. We've built 3 products make up the care management suite. One for identification, one for workflow, and one for analytics. Starting with the identification product. It's the Population Builder Stratification module. It's built and powered by the Health Catalyst data operating system and leveraging Population Builder. Stratification module contains pre-built content, bringing together your claims and your clinical data in a rapid and transparent way. Population Care Flow is our new workflow product. It's integrated and end-to-end application that takes the user through the entire care management workflow process. And lastly, for analytics, Population Care Insights. This is powered by Health Catalyst Leading Wisely, and it delivers operational, financial, and clinical metrics required to measure and maximize ROI for your care management programs. All these applications work together in an integrated and transparent way. But that's not enough. You also need to partner the products with services. And lastly, I would like to highlight real quickly some of our expert services that work with our products to help deliver real ROI. Services around optimization, assessment, population design, program design, and evaluation of your programs. So with that in mind, I'd like to talk about how we approach building the care management suite. Everything we do with the care management suite has the patient in the middle. So we took a patient-centric approach. The importance of that, coming off that, is to ensure that you're building transparent and flexible algorithms to help identify and select the right patients. In addition, you need consolidated and longitudinal patient-centric views of all the data of your claims and your clinical data integrated together. Data and analytics need to drive the workflow in the assessment process. You need to have analytics that are driven by ROI and build ROI metrics that support that, partnered with services to really drive the changes in your care management programs. And then you need to take the results of your analytics-driven ROI metrics, and you need to go back and optimize your stratification process, always thinking about ROI in mind. All of these work together to support your entire clinical care pathway in an end-to-end solution. Okay, so let's walk through the new care management suite and demonstrate each of these elements. So this is a prepared demo, and as I walk us through each piece, I will tie that concept back to the trends that Amy laid out earlier. First, let's start with transparent and flexible algorithms. We will use Population Builder Stratification module to loosely create targeted care management models that Amy referenced earlier. Population Builder Stratification module brings together your claims and clinical data, allowing the user to build a comprehensive algorithm. We will end this section of the demo with an algorithm that we can then save and leverage in our care management program. Okay, so we're in Population Builder Stratification module. I'm going to grab the patient filter, and I'm going to make sure that they are alive and filter that first. Then I'm going to grab facility account, and I want to go and grab admit dates within the last year, and I want to look for patient class of inpatient. So I'm kind of loosely building and showing how we can build a model that Amy referenced, or the Medicaid model. So we'll go ahead and grab financial class description and grab a Medicaid. And we want to go up and check to see if they had 2 or more inpatient visits within the last year. Okay, now we want to do the same thing for emergency visits. So to make that quicker, I can click the duplicate button here. I can now grab this, change inpatient to emergency, remove inpatient. I can make sure we're still looking at Medicaid patients within the last year. Instead of 2 or more, we want to look for 3 or more ED visits within the last year. Okay. Now I'm going to grab a filter over here around patient populations. These are pre-built populations within Population Builder Stratification module that are transparent, can be configured and customized for your environments. But once you've built them, we can go ahead and use them in other populations. So I'm going to grab some based on the CMS chronic condition warehouse definitions, and I'm going to grab asthma patients, diabetes, COPD, hyperlipidemia, heart failure, and hypertension. Click apply. Now I'm going to grab the risk filter. I'm going to look at a risk model that was built out using machine learning and data science around predicted readmission. Again, transparent, open, and configurable for each environment we work with. I'm going to go ahead and say we want the most recent risk score, and now I can take the 1.85 million patients and execute this and get it down to 305 patients. Let's go ahead and save this as complex care management. And now we have a population that we can feed into our population care flow tool. So before we continue the demo, I'd like to now tie it back to the trends that Amy discussed earlier. Earlier, Amy discussed how Medicaid patients can be effective in complex care. She also discussed the increased awareness of bias in algorithms. Both of these trends point to the importance and the need for highly sophisticated, flexible, and transparent approaches to building your algorithms. So continuing on, I would now like to move on to the importance of a consolidated and longitudinal patient-centric view. Claims and clinical data are brought together to ensure a complete view for the patient. We're going to pick up the story in population care flow. This is where the complex care management patients have been recently uploaded. So here we're logging into population care flow. Here is the home page where a care manager would usually live to start their day. But I'm going to play the role of an intake user or an outreach specialist. So I'm going to go to the Patients tab here, and I'm going to go to Need Qualification. And I'm going to go ahead and filter on the source of complex care management. So here are those patients that we've identified earlier. But I'm going to go ahead and search for a particular patient. I want to continue the story with one patient in mind. And that patient is Eliana. Oh, let me fix that misspelling there, Eliana. Okay. Here's Eliana. We'll click on Eliana here. We can see some basic information here on the overview tab, but I'm going to jump to medical history. And the first thing I want to do is the outreach is I want to go look at their medical history in a new tab. Clicking on that, that opens up DOS charts. Here we can see an integrated view of the claims and clinical data brought together for Eliana. We can see basic medical history information around like encounters, diagnosis, and procedures. And again, this is bringing together all your disparate data sources in one view. But I'm going to jump down and look at patient populations. So we know that we included hypertension in our definition, as well as diabetes. But I'm also noticing that Eliana meets the needs for the chronic condition warehouse definition of depression. We'll continue that story in the next clip. But first, let's go back and tie this to the trends that Amy discussed. Amy mentioned the trend around Medicaid patients, specifically the CareMore model. Amy pointed out that data is key and is needed for various data sources. She also mentioned the importance of precise patient targeting. This is why we built our care management solution on top of the data operating system, and that supports the entire clinical pathway. And that allows us to bring and show a consolidated and longitudinal patient-centric view. Next, let's see how the data and the analytics we have gathered so far drive the assessment and the workflow process. We will continue the story with Eliana after she's been enrolled for the complex care management program. The outreach user, as we noticed earlier, noticed depression and has already assigned her a care manager and a social worker. So the story is going to continue with the care manager and our new population care flow application. So the first thing that the care manager wants to do is go ahead and add an assessment and do a PHQ-2 depression screen. Go ahead and assign that to myself. And I'm going to go ahead, I have the patient with me, and I'm going to go ahead and click on the assessment and conduct this assessment now. So here it is, and I'm going to go ahead and ask the questions about little interest or pleasure in doing things, as well as feeling down, depressed, or hopeless. I'm going to go ahead and finalize this, and when I do, that will go ahead and score this assessment. If I hover over here, I can see that the score was a PHQ-2 of 4, and that it tells me here that individuals scoring 3 or higher should be evaluated further. So with that, I'm going to go ahead and jump to the Problems, Goals, and Interventions tab here within Population Care Flow. So knowing that depression is something else we want to focus in on, we're going to go ahead and add some problems, goals, and interventions. So we're going to add a mental health domain for a problem with patient has a history of mental illness. And we're going to save that. We're going to go ahead and add a goal. And all these drop downs you're seeing are configurable and set up by our end users, or you can put in free text as well. So I'm going to put in psychosocial and find a therapist to walk through problems or challenges. I'm going to save that. Now I'm going to add a barrier. What's a barrier to obtaining these problems and goals? A lack of access to healthcare. Unable to get an appointment with a specialist. Great. Now as a care team, what are we going to do to help? So we've agreed to help by referring to a social worker. Let me type that in here. This is a coordinate care, and we already have a social worker identified on the team. I'm going to go ahead and say, let's do that by Friday. And I'm going to associate this to the goal of finding a therapist to talk through problems or challenges. And I'm going to save that. Now, lastly, what did the patient agree to do? So in talking to the patient agreed to call a specialist or call a therapist. This is a high priority item. And again, it's associated with the goal of finding a therapist. Now that we have these basic elements in place, we have the start of a care plan. So now I'm going to go up here and actually generate a care plan. Here you can open up the care plan dialog, and you can customize and configure what you want to include in the care plan. So starting with care notes, let's go ahead and add the initial outreach note when we enrolled Eliana. Let's include all the various problems, goals, and barriers. Let's add the results of the PHQ-2 assessment. Let's add some additional care management information, as well as patient details. And lastly, what's our reason for communication here? We'll go ahead and say new patient care plan. Now we can preview this. And now we can see this configurable and customizable care plan here for you with all the different elements that we chose. Looking good. We'll go ahead and generate that. And now that care plan is stored within the Documents tab. Here, we can click on that care plan and view it, download it, print it, or we can even export it and send it out to an EMR system. Okay, honestly, all the trends that Amy discussed earlier point to the importance of data and analytics driving your care management workflow. But I'll highlight one. I'll highlight the BMJ article that discusses that patients that are vulnerable to poor outcomes and that they're a high risk for poor outcomes. So with that in mind, we need to be able to adapt your care management programs based on new data and analytics impacting the world today. Okay, a few more to go. Now let's look at how to drive your ROI. And in order to do that, you need to look and monitor operational, financial, and outcome analytics. Evaluation methods are crucial. So what we'll do is we'll now jump into Population Care Insights, powered by Health Catalyst Leading Wisely as a VP of Care Management. So here we are. And I'm first going to look at a historic view of various operational metrics that we can look at that are key to monitor with all of your care management programs that you have, things like qualification details, etc. Now I'm going to continue the story on the complex care that we've been looking at. So here's a complex care dashboard we created for this particular program. Here we can see an overview of the program, and we can see different measures laid out here, like discharge, percent discharge with goals met, for example. And we can see how that's trended over time. And we can see that when we started versus now, and that things are trending well. We can look at things like 12-month medical costs, prevalence of chronic conditions with this population, current caseloads. And then we can scroll down here and look at cost and utilization metrics. We can look at like the total population, total medical pay PMPM versus the complex care management population. And we can see, for example, how the trends have, the complex care management population has trended, as well as look at inpatient admits per 1,000, as well as ED visits per 1,000. Also, we can monitor and look at various clinical quality metrics. I'm going to scroll back up, and I'm going to focus in on one metric over here to the right on percent disqualified due to incorrect algorithm. So we can see that in December 2019, we made some changes to kind of make our algorithm a little more efficient, and it's doing much better, but we're still hovering in the 30% range. So as we continue, we'll see about how we can use this and use ROI to even do a better job in the stratification process. Okay, so Amy mentioned the trend of this around the Camden Coalition and the importance of evaluation methods and how crucial they are, and to invest in both the long-term evaluation as well as looking at key metrics in the short term, and that it's a rigorous process. Well, Population Care Insights allows you to monitor your immediate effectiveness. With our expert services, we can monitor long-term effectiveness of your program and really look to drive ROI. Okay, last but not least is the importance of optimizing your stratification process based on driving ROI. We're going to go back and change the algorithm based on improving the qualification process. Maybe we possibly need to fine-tune the program with new sources of data or world events that impact your overall care management process. In this last clip, I'll show you how an analyst can go back into Population Builder Stratification module and make adjustments to the complex care management algorithm. Okay, so we're back into complex care management algorithm we built earlier. And one of the things that we can do is go ahead and use the data we generated within the care management workflow tool, Population Care Flow. Here we can grab the assessment filter, and we actually could take this and look at the PHQ-2 results. Maybe we want to take complex care patients that also had a PHQ-2 over 3, for example, 3 or greater. And we want to build a program specific to depression as well. So we can do that, execute that, and then we could save that and feed that into the workflow tool. Or let's take that away, and let's say a world pandemic hits, like COVID-19. So we can grab the stratification module diagnosis filter, which has claims and clinical data all integrated together. And we can go and search through here and look for COVID-19. And we can look for confirmed diagnoses and apply that. So now we want to possibly build a program for COVID-19 survivors who are also have been in the complex care management program. So we can go ahead and save a copy of this, name it COVID-19. And now we have something that we can feed back into Population Care Flow and can continue to work through the product. I'd like to end the demo by going back to Eliana. I want to show how we can optimize and adapt due to COVID-19. So I'm going to go ahead and add an assessment for Eliana, and I'm going to add a self-assessment because Eliana's in a high-risk group for contact if she were to contract COVID-19. So let's do the self-assessment with her. I'm going to ask her these questions. Have you been within 6 feet of a person with a lab confirmed case? She said yes. Oh, whoops, I actually didn't put no. So let me put yes. And based on that, you see the questions change based on how you answer these. And does the person with COVID-19 live with you? Yes. And then finally, are you having any of these symptoms? And now we can see right here the results of filling out the survey and seeing that at this point, manage symptoms at home and everything, and to assess her symptoms. And if she has any later, we can redo this assessment. Okay, so back to the trends. Amy discussed COVID-19 and COVID-19 survivors, and she used SARS as an example of the potential long-term impacts to patients. This all points to the importance of a care management suite that is adaptable and can be optimized. She talked about the need that, or with that in mind, That means we may need to build new stratification routines quickly and on the fly. We may need to implement new workflows. All of that in mind is important as we think about an ROI optimized stratification process. With that, I'd like to turn it over to Brooke for another poll question.
All right, thanks, Darian. So we're going to go ahead and launch our second poll question. We'd like to know, what do you see as the greatest challenges in care management? Your options are data availability, realizing ROI, return on investment, identifying and prioritizing the right patients, patient/provider engagement, or other. I'll give you a few seconds to get your votes in. Thanks again for participating in these polls. A couple more seconds. And we will go ahead and close that poll and share the results. So it looks like we have kind of a split. 25% said data availability, 18% said realizing ROI, 20% said identifying and prioritizing the right patients, 31% said provider and patient engagement, and 6% said other. Is that kind of what you expected to see, Darian?
It is. Thank you, Brooke. And I think that's a good segue into some my final slides here. So what I just saw in those poll results and kind of what we just went through really goes back to what to the importance of what I'm calling the care management flywheel. It points out the importance for a patient-centric approach with the ability to build transparent, non-biased, flexible algorithms, a consolidated and longitudinal patient-centric view, allowing the data and the analytics to drive the workflow and the assessment process, to have analytics-driven ROI metrics, and then to optimize your stratification process and continue to rinse, repeat, and over again, always thinking about improving ROI and the quality of life for the patients. I'd like to close with highlighting the applications one last time. When we designed the new care management solution, we took a data analytics driven approach with transparent, flexible algorithms. And hopefully the brief demo that we went through shows that. We have the identification process with population builder stratification module, with the workflow tool of population care flow, partnered with the analytics tool of population care insights. All of these products working together with our expert services help deliver real ROI. Thank you.
All right, thank you, Darian. Before we move into our Q&A session with Darian and Amy, we wanted to remind you about our annual Healthcare Analytics Summit, or HAS as you might know it. HAS will be held virtually this year, September 1st to the 3rd, and our theme is the transformative role of data and analytics in the new normal. We will be featuring speakers who've battled COVID-19 in the trenches, as well as other speakers who will discuss adjusting and pivoting to this new normal. We plan to provide a unique and innovative experience, including national recognized keynote speakers, a few of which you can see listed here. We'll be announcing more soon. And we'll also facilitate individual connections with throughout the summit with Analytics Walkabout, networking with Braindate, and many other virtual activities. We're really excited about this event, and we have a lot of fun things planned, so we hope you'll be able to join us. You can get more information and register now at hassummit.com. And we'd like to give away 3 complimentary passes right now. So if you know that you're able to attend HAS and you're interested in being considered for one of these passes, please go ahead and answer this poll question that I will launch right now. So we'll give you a couple seconds to answer that. And then we'll move on to our last poll question, and then we'll move on to the Q&A session. So give you a couple more seconds to answer. And we will go ahead and close that. Hopefully you've had a chance to vote. And we'll close that. All right. And then we're going to move on to our last poll question. So some of you may want to learn more about the Health Catalyst Care Management Suite, or maybe you'd like to learn about other products and professional services at Health Catalyst. So if you are interested in learning more, please answer this poll question. And we'll go ahead and leave that open for a moment as we begin the Q&A session. And Amy Foster, who you heard from at the beginning, will be moderating our questions today. So I will hand it over to Amy.
Thank you so much. So I am going to start with a question that actually was submitted just before the webinar. And that is, how should a health system think about balancing the need for quick evaluation results with what happened in the Camden Coalition example, where there was no impact in a longer term evaluation? I think I addressed this a little bit when covering that slide, but I think, there is a tension there. I think for those of us with operational roles, those of you on the line who run care management programs, you understand the need for having data and having information on impact and outcomes early and upfront so that you can modify the program, change the patients you're selecting, justify the spend on the program to leadership in your organizations. And so I think there has to be a balance of having directional information up front with also investing in longer term evaluations. I think that there are a number of ways to accomplish getting information up front using the tool that Darian demonstrated, Patient Insights. I think that using our evaluation tool, you can almost immediately track outcomes from your care management program. So you can see whether admissions are going up or are flat or are going down. Is total medical expenditure going up, down, or flat? You can see it just for your population, which runs the risk of regression to the mean, as we discussed. But you can also structure a cohort or a comparison population to see whether the changes in your population really are due to care management. So I think that you can, I don't think it's an either or question. I think it's a both. You need both short-term information on impact as well as to invest in long-term evaluation. And I think they serve different but both important purposes. So I think, Darian, you're going to take the next question.
Yes, thank you, Amy. So the question came in around timely identification of new patients is crucial. How long does it take for claims data to be available for use by the identification tool? Great question. First of all, completely agree around the timeliness. And so how I think about that is the integration of the clinical and the claims data together to create that comprehensive data. So yes, the more quickly we can obtain that the claims data, I'm sorry, the better. A lot of times there is a claims lag and we're aware of that, but bringing that data together within the data operating system allows us to bring all claim sources, all clinical data sources. So as new data flows through, albeit claims or clinical, the algorithms will change. Those definitions are already pre-built. A new patient would flow through and be identified and would be loaded into the population care flow tool. So in terms of claims lag, I know it can vary by payer and where you're getting that source, but do know that we look at all the data available, and as soon as it comes in, we can obviously change the algorithms will automatically update and load those new patients. Great question.
Great. I will take the next question, and that is one that was submitted during this webinar, which is, can this new system be used by pharmacists in a pharmacy? And the answer is yeah, absolutely. I think that one of the strengths of this tool is it's flexible and configurable. And so there are a number of pre-built populations and assessments that come out of the box, but we've seen in discussing with clients a lot of different needs for these tools. And so certainly an organization could, for example, create certain cohorts in the stratification tool. For example, patients with certain disease states that need care management, and then similarly could create customized assessments. And I'll share that there's a beta client that we're working with now that is focusing on using this tool for its pharmacists. So that's definitely a yes.
Thank you, Amy. I'll take the next question here. Would the new suite allow us to invite community partners to view and update care plans? So let me give a quick generic answer before I specifically answer that. So obviously today I only highlighted some of the features that are built out in the limited time that I had. But I want to let you know generically how we are approaching features as they come in, and then I'll answer this specific question. So our approach as we continue to drive forward and continue to invest in the new care management suite is to build features that support driving the changes in care management and kind of back to that flywheel that we talked about. So with ROI in mind and the patient in the center, That's how we're going to continue to invest and look at what features to continue to build out in the future. So for the specific question, would the new suite allow us to invite community partners to view and update care plans? Today, yes, they can view the care plans. We can allow those community partners to have access to those care plans and be able to have those by either sending them via email or exporting out to EMRs, et cetera. At this point today, we do not have the ability for those community partners to update those care plans. But again, that's why I gave that generic answer first. So as we continue to invest, we can look at continue to add features like that one. So thank you for the question.
Okay, I'm going to address a question related to COVID-19. How can Health Catalyst's new suite identify COVID-19 patients and support the care programs you mentioned? So there are a lot of use cases that I could cover here, so I'll touch upon just a couple, but if there are ones that you had in mind with the question, feel free to contact us after. I will say that some use cases that we are sort of already hearing about and are ready to support are one, using the stratification product to create cohorts of patients that are COVID-19 positive so that those patients can be care managed and tracked over time. And to the point that Darian was making, I think one of the really powerful things is using both clinical and claims data so that patients that may be in your risk contract or in your ACO who have COVID-19, but who did not get tested within your system, and therefore you don't have their results in your clinical record, can still be identified and cohorted based on claims data. So that might be a patient in your ACO or risk network who went to a drive-in clinic or got tested out of state or was in a skilled nursing facility and tested positive, who for whatever site they got tested is not appearing in your clinical record system. Using our care management tools, you can create a COVID-19 positive cohort, care manage them, and really track that population. So that's one example. A second example that we're in the process of finishing up build is an algorithm around patients that are at high risk of poor outcomes from COVID-19. What I will say is I think that one of the strengths of our tools is that you can really customize and configure the algorithms that you develop and the cohorts that you identify. And I think in COVID-19, that's particularly important because so much of, the expression is all healthcare is local, and I think much of COVID-19 is local. Within your system, you may say, we know that zip code A, B, and C are particularly vulnerable, so we want to care manage and cohort those patients. Or perhaps you want to create a high-risk group of patients that have pulmonary disease and go to your pulmonary clinic. So we've created kind of a foundational algorithm with criteria that are all evidence-based and in the literature that are high risk for poor outcomes of COVID-19, but would encourage any user of the tool to add in their own local and specific criteria. So those are a couple examples of how the tools can support cohorting for COVID-19, but there are many others I haven't covered and happy to talk more offline.
Okay, thanks. I'll take the next question here. Other providers / clinicians typically use the EMR. Does this system integrate with the EMR, i.e. share assessments, PGI, and other info, and is this real time? Thanks for the question. So I think I talked about and demonstrated in the demo itself the creation of a care plan. And so I'll start with the care plan. So the care plan in itself, which includes the assessment information, the problems, goals, and interventions, and some other info, can be shared with the EMR, and that will be via HL7. So it will be, kind of pretty close to real time. Now, the question probably is after the basic elements like the problem, goals, and interventions, and the various components. And with that, we would call that, closed loop functionality. And that is definitely something that is on our product roadmap to continue to invest and build that out. So thank you for the question. Brooke, I think we'll turn it back over to you.